your hormone is not responding to the stress of fasting. So it's not getting you to mobilize all these things that cause euglycemia. So imagine if the block is here, as I have said before, you have high lactate, high pyruvate, metabolic acidosis. Okay, so metabolic acidosis and other biochemical features like this, like lactate, also is a clue. So that's the second clue that I would like to present to you. Right, next. So many hours after fasting, you can also get non-ketotic cause of hypoglycemia, and this is fatty acid oxidation defect. So fat is mobilized many hours after. That's why if you want to lose weight, right? So you don't eat for many hours, all your fat will be broken down, you'll be thin. No, it's not true. Anyway, right. So now, helpful clues: ketones, timing of hypoglycemia, biochemical supportive evidence. But actually, one very, very important thing to us clinicians is history and examination, things that you get for free. So things which are involving multi-system, like if the child or the adult person has short stature, has big organs, has myopathy, has dysmorphia. So our children with glycogen storage disease type 1, we say that they have this round face doll, like a doll. And they're very cute looking, round face, round eyes, you know. So that is actually dysmorphic features by itself. Family history is very suggestive, like the one that I presented, consanguineous, other members of the family affected. So we recap the first patient. She has hypoglycemia, recurrent. It is after many hours of fasting, or if she's vomiting, or is associated with not eating, anorexia, because she's not well. There's lots of ketones, there's metabolic acidosis, high lactate pyruvate, and there's glycerol. So our differential diagnosis, maybe glycogen storage disease, maybe gluconeogenesis defect, like glycerol kinase, as I've shown you, or fructose metabolism. And this is actually her result. Can it be seen? It's tiny, right? So basically, we did a genetic test on her, and her FBP1 gene, there is a mutation there, homozygote mutation. So homozygous is not surprising, isn't it? Because her mother and her father are related, so they carry the same gene, it's in the family, right? And this confirms the diagnosis of fructose 1,6-bisphosphatase deficiency. It's an autosomal recessive condition, right? So now let me introduce you to the second patient, NS, and she's 25 years old. And the scene is set. It is Monday night, 10 o'clock, accident and emergency. She came in because she fell downstairs, and she estimated that it is 10 feet height. She has a pain in her left flank, and she had blood in her underpants. She was very well orientated and conscious and alert, and she tells the attending physician, I have a history of hypoglycemia since 3 years old. I cannot fast. During fasting month, I don't fast. I eat. Okay? Right. So to attend to her immediate problem, she had x-rays done. She had a lumbar vertebrae fall, fracture, and then she had abdominal pain and guarding and blood on her urinalysis. So what happened was she had a CT scan of her abdomen, which was reported normal, but in any case, she was admitted for observation, and she was kept nil by mouth. No food. So how would you prescribe fluid for this young lady? Have to think for 2 seconds. Right, because actually the choices are abundant, isn't it? It's like going to order tea from Cha Time. So you want less sugar, more sugar, no sugar, slight sugar. You want a large, a medium, or a regular, or a mini, or whatever. You want to add some toppings, maybe? Okay, so there are so many. So there's the dextrose 5% plain, there's the dextrose 10%, there's a normal saline with no dextrose, normal saline dextrose 5%, half normal saline, which we use in pediatric because they can't tolerate so much salt. So D10, or you just want to, custom made your own one, right? So actually what was given to this young lady is normal saline, dextrose 5, and she got 2 liters per day, 4 pints a day, with no added toppings, right? Okay, so the next morning, 7:15 in the ward, what happened? She was tachycardic and tachypneic. altered conscious level, and somebody checked her dextrostate very sharp. It was 1.7, she was hypoglycemic. So she was given a bolus, 50%, 50 mils straight away. Her sugar went up to 18.3. And at the time, she had metabolic acidosis, quite severe. Bicarb is only 5.6, base excess minus 19.6. She was seen by the anesthetist, and because of tachypnea and severe metabolic acidosis, she was intubated and ventilated. And I copied this from her notes. Differential diagnosis, query sepsis, query diabetic ketoacidosis. So of course, with our retrospectroscope, and after freshly reviewing our glucose homeostasis, this cannot be DKA, isn't it? Because the sugar is low, it's low sugar, right? Okay, so anyway, she was kept new by mouth, and she continued on her normal saline D5, 4 pints a day. 10:30 in the morning, 3 hours later, her sugar is 0.8. Oh, yeah. What happened? Right. So 0.8 was her sugar. She was comatose. She was given the 50%, 30 ml stat. Her repeat sugar is 3.2. No metabolic acidosis this time, which continued on the same fluid regime. And then 5 hours later, she was more stable. She was started on NG tube feeding. She was still intubated at this time, and a Cal 200 ml 3 hourly was given to her. So, in the past, this young lady has this history, right? So she was born, and then she had multiple episodes of virally infections, admitted to hospital with hypoglycemia. Sometimes she was ventilated because she had fitted. Sometimes she has weakness, she cannot walk. And sometimes the sugar was checked, it's hypo, sometimes it's not checked, we don't know what it was, okay? And so she lived all this time, and then she met us, we met her when she was an adult, okay? Right, so she also has normal cognition. She was working, paying taxes, she has no family history, and she had a fasting tolerance test. As you can see, as she fasted, her lactate came up, her ketones came out, and at 15 hours she became hypoglycemic. And it was symptomatic, she was sweaty and dizzy, and so this was terminated. A critical sample was taken. So critical sample is samples of blood and urine that we take when somebody is hypoglycemic. So it's a stress sample, right? And we also found lots of ketones, just like the other girl, in her urine organic acid. So differential diagnosis, same one, right? And her diagnosis, same one actually. She has FBP1 gene mutation. This is a compound heterozygote. So again, like classical textbook, her parents are not related, so they carry different gene. So unlucky, they met and fell in love and had this girl. So she has fructose 1,6-bisphosphatase deficiency. That is her diagnosis. So I would like to quote Sir Arthur Conan Doyle, who writes Sherlock Holmes, right? But in his other book, Boscombe Valley Mystery, he said, there is nothing more deceptive than an obvious fact. So the obvious fact here is her problems, apart from falling down, is hypoglycemia. She was fasted and she was hypoglycemic. This caused everything, her admission to ICU, her being intubated. She wasn't septic. She didn't have a myocardial infarction. She definitely didn't have diabetic ketoacidosis, right? Okay? So just a few words, quick one. Fructose 1,6-bisphosphatase deficiency, this is the chemical structure. So there's a phosphate at 1 and 6 positions, so it's not important, this one. The effect of hypoglycemia is glucose is like an oxygen. It is essential and fundamental for brain metabolism. So, as Mary Poppins has beautifully sung, a spoonful of sugar helps the medicine go down, right? But for this group of patients with glucogenetic defect, actually the sugar is their medicine. It doesn't help medicine to go down. This is their medicine. Give them sugar. Sorry, dentist. They need sugar. Right? Okay, right. So now, So the effects of hypoglycemia is divided into two groups: autonomic or neuroglycopenic. This is in the immediate period, straight away, acute period. So as you can see, basically autonomic, sweating, pallor, tremor, feeling of nervousness, hunger, tachycardia, high blood pressure, all these are very non-specific. Lots of things can cause this. If you have bled out, you can have that. If you had like an MI, you can have that. If you have to give a talk on a Wednesday morning to senior colleagues, you can have that also. Yes. So basically, but as sugar is lower and lower for a long period of time, it affects your central nervous system, and you can be irritable, confused, you can have seizures, and then you can go into a coma and you can die. So now the long-term effects is cognitive impairment, and I quote one article about a woman who has got 3 pregnancies, and she has fructose 1,6-bisphosphatase deficiency. So her sugar was managed with uncooked cornstarch, because uncooked cornstarch usually cause your sugar to be at the same level in the blood throughout the day, right? So with that, she had 3 pregnancies to maintain her sugar. She didn't have symptoms of hypoglycemia, but after 3 pregnancies, she actually had hearing impairment and cognitive deficit. So maybe she had asymptomatic hypoglycemia intermittently. It affects your brain. Okay? So fructose 1,6-bisphosphatase, not common, 1 in 20,000. But with helpful clues, we can make the diagnosis. And the management is to avoid hypoglycemia. Sometimes we use cornstarch, sometimes we don't. Especially when they are fasting or when they are ill, when the metabolic rate is high, we must remember we need to supply them with sugar. Okay? So in acute hypoglycemia, we rescue with bolus. And I want to put a highlight on the maintenance. Okay? How do we choose our fluid? Like I asked you just now, right? There are lots and lots of choices. So many things you can choose. So basically, it's based on theoretical knowledge of how fast the liver makes sugar. So in children, the liver makes sugar at this rate, 3 to 8 milligram per kilogram per minute, every minute. So the smaller you are, the neonates will be 8 milligram per kilogram per minute. The older child will be 3 milligram. And then when you are an adult, you make sugar at a slower rate, but you make a lot of sugar because your kilogram is bigger, right? So therefore, when we think about glucogenesis defect, that means your liver cannot make sugar. Right? So when they are ill and they are not eating, what do? We need to give them the sugar at a rate at least matching the rate that the liver would make sugar. Correct or not? Right? And in children, we give them a bit more, 10, okay? A little bit more, because your high metabolic rate, imagine you are having fever, you are having vomiting, things like that. So you need to match that, so a bit more. In adults, there are actually no recommendations. So it's a research project for somebody, if you like. So I say 3, roughly a little bit more. So how do we supply 3 milligram per kilogram per minute sugar to a 50 kilogram lady, which was our patient, and as she was 50 kilogram. So a little bit of maths for you. What we want is 3 milligram, okay, times 50 kilograms, 150 milligram of sugar in a minute. 1 day is 1,440 minutes, correct? So in 1 day, she needs 216 grams of sugar. Right. So if we choose dextrose 10%, the definition of dextrose 10% is 100 mils, there's 10 grams of sugar inside, right? So to get 216 grams of sugar, we need 2 liters, 2.16 liters of dextrose 10%. And actually what she got was 4 pints, which is 2 liters, of dextrose 5% normal saline. So it's half, less than half, because the volume is less and the concentration is less. So there's no way she could have maintained normal glycemia. No way, because she can't. We need to give her the sugar, right? So think about this. This is the what I wanted to say actually, right? So what would you choose? You need to custom made it, unfortunately. There is no such thing as normal saline D10. And so you need to add you take dextrose 50% and you can do the calculation yourself. If not, then please come and see us in the clinic. So, and then what would you choose? Would you add something? We would generally add potassium for maintenance, right? Because, when we are given fluid, we're not eating. Okay, right. So the treatment is to avoid hypoglycemia. Secondly, avoid a big load of sucrose and fructose. Sucrose is found in table sugar, the one that we put in coffee and tea. Fructose comes from fruits, honey, and things like that. So we cannot give them a big dose because that will cause a block in the pathway, right? And they'll become metabolic acidosis with lactic acidosis and hypoglycemia. But in older people, in adults, we find that they can tolerate fructose more and fasting more because the liver glycogen store is more. So they are less dependent on gluconeogenesis to maintain blood sugar in the circulation. And so the role of dietitian here is very important as they grow and they attend us. They always see the dietitian who tells them what they can or cannot eat. They're on a special diet. So the take-home message, ladies and gentlemen, think about metabolic diseases with hypoglycemia. When you have these helpful clues, when they have childhood onset, family history, and the timing of the hypoglycemia, if you have multi-system involvement with a big liver, and biochemical supportive evidence, and avoid hypoglycemia at all costs in this group of patients because we want to preserve their brain. Okay? So I'd like to thank the families and the patients and my colleagues. Any questions?